with the Dr. Joe Show with Dr. Marks talking about Alzheimer's and the future of Alzheimer's, which may be going away soon.
Let's clarify what that statement
No, I like a big statement.
The future may be
20
going
years.
away soon.
20 years from now.
I mean, Alzheimer's.
Correct. I think the listeners knew what I meant, didn't they?
I hope so.
Listeners, did you know what I meant?
So. I think so. But it's an interesting thing. We've got so much to talk about here. So where were we when we left off? We were talking about vaccination idea of Alzheimer's, but that there actually may be now a medicine that could work?
Yes, there is a medicine that works at worst marginally, at best a little bit more than marginally. As I said, it's a bunt single.
Yeah.
And the point is you can't stop with a bunt single.
Right.
So where do we go from there? That means getting people engaged in clinical trials, volunteering to be in trials. If you're the child of someone who has had Alzheimer's from a parent or a sibling and you're over the age of 55, there are national clinical trials. We're involved in one of them that are looking at people who have evidence of the abnormal amyloid protein we talked about but have no symptoms yet. And the idea is to see if we can prevent it from ever progressing.
Yeah.
These medications, by the way, do not change what your behavior is now. Whatever damage is done is done. The idea is to try to slow down the progression, not necessarily even stop it, but slow it down. I don't know, maybe you live another 20 years and you die of terminal baggy skin. But, the point is that is to try to extend it out. I mean, that's what cancer goes. It's you may not, quote unquote, cure it, but if it's kept at bay till you die of something else,
right,
okay.
Right.
It's true. With so many chronic illness, like diabetes as well. You're just trying to keep things under control.
Right.
We had a call in. Actually, it was a text from Paul Zani, who actually was a director of some of the psychiatric hospitals I worked in. He said, "How are people meant to afford this? If they're on Medicaid, how do you afford over $50,000 that's going to be out of pocket, right?"
No, Medicare is working on it. Look, in the United States, under George Bush II, it was decided that Medicare could not negotiate for price. In every other country of the world, there's negotiation for price. The U.S., through the NIH, which funds most research through universities, and through our pricing of drugs, supports drug research for the entire planet. And this is a political issue, and it's difficult. In Massachusetts, the major teaching hospitals make money off of doing research. And so if you cut down the research dollars because you try to drive down the price of the drug, it cuts both ways. And so it's a thorny problem, but obviously a lot of us are hoping that this may be the tipping point. It's finally the drug that is expensive enough and is used by enough people that there's no way that they can't finally come back to that fundamental problem. So Medicare right now, there's 10 regions of Medicare across the country called MACs. There's an intermediary agency that negotiates for the region. And each of the MACs is separately figuring out how they're going to handle it. Medicare has a select committee trying to figure out how to deal with this. It gets more complicated because in order to diagnose the disease, we don't have a blood test just yet. So you have to either do a spinal tap, which is not as nasty as it sounds, to look at for the amyloid, or a very expensive nuclear medicine test called a PET scan. And the PET scans run $4,000 to $5,000 out of pocket. Medicare did a study a few years ago, we were involved in that as well, looking at whether or not it was beneficial to do an amyloid PET scan to help with diagnosis. It clearly was. It's not paid for. Medicare, I am told, from what I've read in the last week, is reconsidering paying for amyloid PET scans. That's a huge amount of money for Medicare. In addition, these drugs can cause some temporary swelling in the brain, usually no symptoms, but you have to monitor it and adjust the dose based on that. That requires multiple MRI scans. Who's going to pay for that? It's an extremely expensive proposition. The drug trials cost $2 to $3 billion each because they're very complicated looking at all these factors. So it's a great question, and there's not an immediate answer to it. All of us are feeling our way through this, trying to figure out who should be on the drug, who should not, who we would encourage to be in a drug trial. And it's what we call shared decision making. It's not my decision to make. It's a discussion or discussions that we have with patients and families trying to decide the best course of action.
How close do you think they are to a blood test that we can go into our primary care and draw some blood and, okay, you got some amyloids, let's go get the Biogen drug and stop this from happening?
Well, see, it's unfortunately a little bit more complicated than that. We have to first validate, as I mentioned earlier, that the blood test is analogous to what you see in the brain, and they're working on that. The answer to your question is perhaps 2 to 3 years.
Good. Unless the science stops.
Unless
right?
well, the science isn't going to stop on that. But the fact then remains, the primary care doctor should not be in the position of ordering this.
So who does?
That's the problem, is that it should be people who have some experience doing this. And I'm saying that not out of a means of maintaining business, but just in terms of taking care of people. These are primary care doctors are overwhelmed. The best I would hope from a primary care doctor, putting aside what you just said about a blood test, as part of Medicare's annual wellness screening is you have to do a mental status exam.
Right.
A lot of them don't. Some of them do. And the idea is if you see an inkling of cognitive impairment, they usually send them to us to take further.
Got it.
Right.
So you make the referral and then they take a deeper test.
But we're dealing with this right now at a national level. This week in Denver is the Alzheimer's Association International Conference. It started as a little tiny conference about 20 years ago. It's huge now, and because of COVID, it's a virtual conference. And so instead of all people from around the world who couldn't afford to come to these U.S. conferences, now there's tens of thousands of people listening to it. It's an extraordinary conference. So in real time this week, there was heavy discussions about some of the questions that you're asking.
Awesome.
And so it's very much in real time, which is part of the reason I asked Joe if I could be on the show, because this is not just speculation anymore. This is really happening. And so because of my involvement in the research, I see myself as being a bit of the spearhead in terms of our region of getting the knowledge out.
That's very exciting.
Yeah.
June 7th.
Yeah.
That was a big day.
Big day.
And they had delayed it by 90 days and 180 days because the FDA didn't know what to do about it. The independent advisory panel of neurologists said do not approve it.
Really?
The internal committee of the FDA said they would.
Why? Why was there an
For the
internal
reason that
debate?
I told you, that there's the anti-amyloid. That's a good question.
But I already answered it.
I already answered. Damn it! No. Actually, no. That is the core of it. And what it was is that the concept that getting rid of the amyloid, the biomarker, didn't necessarily, based on the evidence that had been produced, correlate well enough to say it has clinical benefit. Okay? In other words, people were saying, yeah, it's great, it's a biomarker, we need to do a little bit more, we don't have enough data.
So what
We
makes
need more tests.
what makes this medicine different? Because there have been medicines that have been out there for Alzheimer's, or at least to slow down the progression. What's different about this one?
The medicines that have been out there have not been to slow down progression.
Okay.
What they do is they treat symptoms. And to go back to what I said earlier, if you had polio in your leg and you when you went to stand up, we're on video?
Yeah.
All right. Okay. So
WATD listeners, I will make the announcement.
You'll do it. You'll do
Don
the
Marks has
play-by-play.
been standing up.
So say you have polio in this leg and you go to walk and your knee buckles and you can't walk.
Yes.
And I give you a knee brace and now you can walk like this. Did I fix the polio?
Now you just...
I just gave you a functional benefit from the brace. Now, let's say the polio goes to this muscle that moves your ankle. So now your knee is a little stabilized, but now your ankle gives out. So you're still getting worse, but you're better than you would be if you didn't have the knee brace, even as it progresses. Okay? That's called symptomatic benefit. That's not disease modification. So we've had oral drugs since the late 1990s that have been good for symptomatic relief.
And what are the symptoms that they're relieving?
They help with attention, focus, memory. They're said to be memory drugs. What they really do is they enhance attention and concentration, which indirectly leads to better memory. If you're more in tune with your environment, more aware of it, more engaged, then you're more likely to retain information.
Like an ADD type of drug.
So yeah, in a way, unfortunately it's somewhat different than that.
Okay.
You still have a fundamental problem with the formation of memory and the ability to go back to memory.
Yeah.
But in a sense, you're right that the if your focus is better,
stimulus.
then you have a better chance of getting it in. But unlike an ADD patient where their memory's working pretty well, they just can't sit still long enough to get it in.
Yeah.
This is both. You have a problem with sitting still to get it in and attending to it, but you also have a problem with it being deposited in your memory.
How painful is it for the patient to try to go back and capture that memory?
For some people, it's extremely painful, and they have what we call a catastrophic reaction. They get very emotionally distraught. For other people, as Ronald Reagan, who had Alzheimer's, said, there I go again. So there are people who have a sense of humor and self-deprecation, but unfortunately the disease affects different parts of the brain differentially in different people. So you can have what's called executive dysfunction. The frontal lobe systems don't work as well in particular, although it's more complicated than that. But the fact is these folks don't know that they have a problem. It's called cognitive anosognosia, not knowing that you don't know. That's hell on wheels for families. Very difficult. Difficult to get those people to medical treatment, difficult for families to cope with it. And so there's a lot of subsets. There are people who have very good executive function. They are socially with it. They appear normal on the surface, but you ask them to draw the face of a clock and they can barely draw a circle. So it affects different parts of the brain in different people. So in a sense, it's probably not Alzheimer's disease, but Alzheimer's diseases. And we tend to lump it together. I suspect over the next couple of decades, we won't see it quite the same way.
So we may be able to tease them apart. This
Yes.
one's this one's that. And
But by then it'll be gone because we'll have had it all figured out by then.
Well, it's going to take a while. There's also going to be a bolus of people who are far enough along. So even if we found a quote-unquote cure that stopped it dead today, you're still going to have a lot of people who will continue to progress and for the next couple of decades.
So we'll watch for that. Alzheimer's may be gone, but I know that our sponsors are not. So we will have our last commercial break for tonight, but we will be back with Dr. Don Marks talking about Alzheimer's. Really important discussion. We'll take a break. Be right back.
Stretch the canvas, brush with